One of the things that some people fear is the anesthesia and going to sleep and then the surgery, and the whole thing can engender anxieties or fears. And we're talking with one of our patients today about the risk that you're just going to get scared. I'm scared of the surgery and I'm frightened, and how will I respond to that? And one of the things we're proud of is, of course, the surgery itself. We believe that it's pretty amazing to have somebody have major abdominal surgery and a couple of days later be here chatting, sitting for a couple of hours in clinic, that they go home the day afterwards, that they're eating and drinking and not having an IV fluid within 12 hours after the surgery. We think the surgery is pretty spectacular, but all we do day in and day out, everything we think about is just this practice, nothing else. And not only are we proud of our surgery, not only am I proud of the website and the process and even the packet, but the anesthesia and the anesthetic techniques that we use are something you have never seen before. It's all brand new stuff. It's all nothing but the best for preparing you for the pre-op process and for the surgery itself. So you had two people here who just had surgery. Neither one complained a bit about their experience with the surgery. We didn't ask them about it. It's too bad we didn't go into that. But here's what we do. First of all, we understand that we're going to be trying to use certain medicines or drugs to get you through the experience, from preparing prior to the surgery and then intra-op and post-op. For those of you who are nurses, you know that the standard for anesthesia for many years included a gas like halothane or enflurane or sevoflurane or something like that, and narcotics. And those of us who are old, we used to use morphine, we still use morphine, we used to use Demerol, and now there are newer drugs like fentanyl and things like that. But narcotics and gas anesthetics were a foundation of anesthesia, and you may have had that with your ankle and foot surgery. Those are great choices. They're not as good as they could be. We have new stuff. And the whole new area is a combination of drugs called TIVA for total intravenous anesthesia, and another area of research called opioid-sparing anesthesia and analgesia. Okay. The gas and the narcotics both can cause nausea and vomiting, and both can depress your breathing, neither of which is attractive, fun, or safe. So we don't use those. We use TIVA, which is a drug called propofol. That's the drug that Michael Jackson got his doctor to give him at home. We like the drug, not at home. But it's a great drug because you go to sleep and it takes away nausea. It doesn't cause nausea. It doesn't stress the heart. In addition to that, there's a whole area of research looking at giving pain relief without the side effects of the narcotics. I want pain relief without the side effects of the narcotics. And they found a whole batch of drugs that now get pain relief without the nausea and vomiting, without the respiratory depression of narcotics. And we use those drugs. So we use clonidine, which is a blood pressure medicine, which has now been shown to help protect you. We use gabapentin, which is good. And then we use an old-timey drug that our mature nurses will remember called ketamine. Now, ketamine is an old drug that is from my time, and ketamine has the disadvantage of causing kind of hallucinations and things like that. Yeah. But they found if they give it a low dose with a bit of another drug, they can block that. Oh. And you get tremendous pain relief, and it stimulates breathing and protects our patients from some of the complications and dangers. Doesn't cause nausea. There's a new drug you guys probably don't know about called dexmedetomidine or Presidex. And this is a drug which, like clonidine, works on the alpha-2 receptor in the brain. You get pain relief, but you keep breathing. In addition, we also use a drug you probably know, and that's called melatonin. Now, melatonin, when given to women having a hysterectomy or women or men having a surgery on their hand, showed that they had improved sedation, decreased pain, and overall increased satisfaction. And what we found is when you get that tomorrow in preparation for your surgery, you're going to be more relaxed. We doubt that you're going to suffer those fears and anxieties you had with your previous surgery, and I think you'll be really happy with the extreme safety and good experience that you're about to see with our anesthesia.
Is that natural to the system? Melatonin? Don't we secrete that?
Melatonin, yeah, it's a metabolic product from tryptophan, the amino acid. It's we used to think it was purely from the brain and cause sleep. We now know it's the #1 amino acid in the gut, and it helps protect the lining of the gut. It's a pain reliever. There's some research that it may actually help protect against Alzheimer's disease. So it's a lot of interesting new stuff on melatonin. We recommend it.
Well, with the ketamine, though, I have children that were given it for their tonsils. Oh, my word. Recovering them was a chore.
Right, because they don't know how. That's a different kind of ketamine. That's a different dose of ketamine. There was, if you think of burns or kids, they use ketamine, but they didn't use the dose we're using. It's called low-dose ketamine.
I see.
Yeah.
Because I was big. Oh no, my son's gonna
Well,
go nuts.
Yeah. Another thing you could do is you can call our recovery room nurses. You can talk. You talk to these patients today.
Yeah.
Talk to my patients and see if they had a bad experience like that.
Yeah.
They don't.
Yeah, I was
Good.
put off by that, really.
Yeah. Well, that's why, in fact, the ketamine was not commonly used. This is new stuff that you don't know about. And if you want to look it up, there's a lot of good research on it. Or you can also look at our patients, and our results are really spectacular.
Yeah,
Safety. In other words, think of putting a breathing tube in a heavy patient.
Yeah,
It's called, as you know, difficult airway.
you're right.
Right? How many of my patients have you talked to that had difficult airway or problems with the breathing? Zero. Yeah, so this new technique, when you had difficult airway, one of the problems, as you know, is you get the sedative. You get the paralytic agent, the succinylcholine, and the patient doesn't breathe. If you don't get the breathing tube in, you got big trouble, right?
Right.
Okay. We don't have that.
Yeah.
Because the drugs that we use, the ketamine and the dexmedetomidine, are non-sedating, so they keep the respiratory drive. So if you can't get the breathing tube in on somebody who's sedated with my surgery, we don't care. Because they're still breathing, because the ketamine and Precedex supports them. It's totally different than the past. Difficult airway is a whole different thing because they're still breathing.
Yeah.
So that's our little story about anesthesia.
And I'm not